I'm Mike Stoltz, and this is Patient Restraints. Learner objectives. So I want you to be able to identify 3 different types of patient restraint, know the policies and procedures for the use of patient restraints, and be able to list at least 3 ethical considerations about patient restraints. Why restraints? I've been a trauma ICU nurse for 4 years. I use patient restraints pretty frequently, and it's kind of a hot button topic because you're taking away somebody's ability to move or refuse care and things like that. You're exercising some paternalism over them, and it's a hot button topic that I thought was interesting. The best definition I could find of restraints was the intentional restriction of a person's voluntary movement or behavior. There are 3 different kinds of restraints that we use: chemical restraints, seclusion, and physical restraints. Chemical restraints are they're medications. The woman on the left is receiving an injection in her arm there. Looks like maybe Haldol or Thorazine. The gentleman on the right is happy and bright on the left-hand side of that picture, but on the right-hand side, you can see he's pretty subdued, and how upsetting that would be to family if you walked in there and saw your father like that, or your brother or grandfather. Different types of seclusion. Well, really, it's just being in a room by yourself, away from other people, usually for violent patients or people who were threatening staff or threatening themselves, sometimes for suicidal ideation. You get put in a seclusion room. Violent restraints, these are all kind of fall under physical restraints too. These are for patients who are violent. You see the woman on the right is in 5-point restraints, has a mask on. She's probably spitting on staff. Here you see physical restraints. That's your physical body holding the patient down. You don't see that very often. That's usually a security measure. These are probably restraints that you're more familiar with. You have the soft wrist restraints. They also go on ankles. The gentleman laying in the bed with a vest restraint on, and the 4 side rails up on the bed, also a restraint. The mitts on the right-hand side no longer count as a restraint, but you're probably pretty used to seeing them too. These are some principles regarding the implementation of restraints from the American College of Emergency Physicians. You can look through those. Joint Commission guidelines for restraints. These are also pretty important. They talk about more the hospital's their plan, their policy for initiating and maintaining restraints. How does the intervention of patient restraints affect nursing practice? I think that nurses see themselves as patient advocates, and they want to do everything that they can to ensure safety and comfort in their patients, but sometimes those things oppose each other, and you have to try to figure out which one is better for the patient at that time. Also, your own safety could be at odds. I found a survey that said that 80% of nurses were assaulted by their patients at some points over their career. So the ethical dilemma that you hit is autonomy versus paternalism. Autonomy saying that they have the right to decide for themselves what they want and act independently, and paternalism saying, no, we know what's better for you right now, and we're going to enforce that and have you do what you want, but do what we want rather, but it's for your own good. Patient restraints in nursing practice. Again, I found this study that was pretty interesting. It was an ICU in a Boston hospital, and they found that nurses have this much more of an influence on the initiation of starting restraints. And we don't order them, we're not physicians, but we can influence physicians to order them and also to discontinue them. So you have a bit of responsibility there. We're bedside, we see the patient more, so they trust us for that. Number 1 reason for restraints, intubation of a patient to prevent self-extubation. Number 2, invasive monitoring. Number 3, falls. And number 4, nurses' safety. There's always injury risk with restraints. You have to be very careful and assess frequently. Most commonly, you see friction, shear, pressure-related injuries, but you can also see anything up to including death. Some things harder to assess are distress, anxiety, and post-traumatic stress. That can also be something that we need to be aware of. Impact of physical restraints on healthcare. So you can see that approximately 27,000 patients are restrained daily in the United States. I thought it was interesting that most nurses admit feeling guilt about using restraints, and that we should consider alternatives before initiating restraints and seek for the earliest opportunity to remove them. I think that you should check each patient individually and make sure that you're doing your best to promote their autonomy. Impacts of patient restraint on society. I think that society looks at restraints in a different light. They don't see them as such of a benefit as we do. They see it as more of a violation of that patient's autonomy, their basic human rights. They probably see it as, it's a convenience thing for us as nurses. Not the case. And you can really alleviate those facts by educating the patient family and the patients and, telling them why we're doing those things and then being ethical about it and getting them off as soon as possible. So ethical considerations before using patient restraints. Assess the need for patient restraints each patient individually. Attempt other interventions before initiating restraints. Obtain consent for the restraints. That can be a doctor if it's an emergency, but most often we like to get it from the patient themselves or from a family member of the patient. Make sure that you're trained and you keep your competencies up, that you know how to use restraints and assess for them and document. Reevaluate frequently and educate your patients and families. Thank you very much. Here's my references if you're curious. Thanks for listening.